Okay, so last video we were covering the neural mechanisms of sleep, and we're still continuing to cover that area. Last time we talked about lesions of the pons and how they abolish REM sleep, and we also talked about the subcorillus and that the neurons in the subcorillus are really important for inhibiting the motor activity that you see during REM sleep. And if you have particular lesions, like for example in the cat studies that were done to the subcorillus, then you see that the cats actually act their dreams out because that inhibition has been cut off and they no longer have the muscle paralysis that you see with REM sleep. Now, we see this in humans with REM behavior sleep disorder, and that is if you, for example, Parkinson's disease, Alzheimer's disease, or traumatic brain injury, where you see a person has particular brain damage, that is likely the cause of this sort of inability for the muscles to be paralyzed during REM. They do act their dreams out, and that can be really dangerous to the person because they can fall out of the bed, hurt themselves, or their bed partner as well. And so just continuing on, the study of disorders, sleep disorders, allows us to understand the mechanisms behind the neural mechanisms behind sleep, because if we can understand what's causing the disorder, then that gives us an idea of what's going on in the brain in terms of that type or stage or mechanism of sleep. And so the study of narcolepsy has helped us really understand what's going on when it comes to this kind of switch from wake to sleep. And so when we look at, for example, there's a particular line of dogs that has a genetic susceptibility to narcolepsy, and that gives us a lot of information on the disease itself. But it's really interesting that it's shown us that the hypothalamus is really important for this transition from sleep to wake. And so a person who is diagnosed with narcolepsy, this is not somebody who's just kind of tired all the time or like snap. This is a person who has these uncontrollable urges to fall asleep. They can't fight it. It is just an uncontrollable sleep attack. So they'll fall asleep. And it could be, for a few minutes, it could be, an hour, it varies in terms of duration, in terms of how long they fall asleep. And then it happens quite suddenly, and it happens sort of randomly throughout the day. And then, of course, they experience this excessive daytime sleepiness just throughout the day. They just never feel rested. Even their nighttime sleep is not really that good quality. It's not really that restful. So it's not like they have this sleep attack and suddenly they feel super good and rested and continue on. They're still really not feeling very rested. And what's interesting is that they essentially go into REM immediately when they go into this sleep attack. Okay. So they immediately go into REM and they experience that muscle paralysis, that muscle loss. So it can be really dangerous because if they are, going into a sleep attack, they'll basically go limp. And that can be really dangerous if they're standing and holding a knife, if cutting their food for making dinner, if they're in the middle of doing something and they sort of collapse, can be a problem. Now, or go sort of limp. Now, cataplexy is a comorbid condition with narcolepsy. You can have cataplexy without narcolepsy. You can have narcolepsy without cataplexy, but they tend to go hand in hand. And this is that sudden loss of muscle tone that will lead a person to a collapse. And a lot of times it's followed by a sleep attack as well. Now, I like to, think about this in the same way as a fainting goat, but it is not the same mechanism. Okay, it is fainting goats do not have cataplexy. It's not driven by the same thing, but it looks similar. So if you scare a fainting goat, they'll actually they'll go kind of rigid and then they'll fall over. And this is the same kind of thing that you see in people with cataplexy, is high emotions. Like if you scare them, or if they are really happy and they start laughing really hard, they'll actually have these episodes where they'll actually kind of seize up and collapse. Now, when you have narcolepsy with it, typically that's followed by a sleep attack. And so they do go unconscious. But when a person has narcolepsy and cataplexy together, it can be really, really, it can be socially harming for them, because they tend to avoid strong emotion because they don't want to have a cataplexic episode. And so they might withdraw themselves socially. So this can be a damaging condition to a person's mood, because, social withdrawal makes you feel like, you might feel depressed because you can't be around your friends. And so there's a lot of therapy that really should go into this condition along with medication. So typically people with narcolepsy are taking both hypnotics to sleep better at night and stimulants to stay awake. So let's look a little bit on the neural mechanism behind narcolepsy. So like I said, there were these particular dogs that have a very specific genetic mutation for hypocretin. So hypocretin is a particular neuropeptide. It's the same thing as orexin. Okay, so there were two groups studying this neurotransmitter at the same time, and they named it something different. So one group was studying it for sleep, and one group was studying it for hunger and cues for eating. And they just named it two different things, but it's the same exact neurotransmitter. And what hypocretin is, there's particular neurons that contain hypocretin receptors. And these hypocretin receptors, their job is basically to help you stay awake and alert. And we don't have a lot of these. We only have about 10,000 projections. It's a very small kind of part of the brain. And when a person might have, for example, a virus or a genetic mutation, and it attacks these hypocretin neurons. So this would be a normal, typical person, and you can see these different neurons available. Like I said, there's not a ton of them, but in a person who has a virus or a genetic mutation or an autoimmune condition where the hypocretin neurons are being attacked, this person here, you can see very, very few of them. You might only have 10%, and it can be progressive. So if a person, for example, has something that's triggered this hypocretin loss, what happens is that they start out with some mild symptoms where, they start feeling like they're having these kind of sleep attacks and urges. And then over the course of, it can be sometimes weeks, months, even years, they lose this hypocretin, these hypocretin neurons. And then progressively they get worse and worse and worse. And so for some people, it actually takes, in some cases, a decade for a proper diagnosis to understand this is what's really going on. A lot of times people with narcolepsy are deemed as just completely lazy and they just want to sleep all the time. And it turns out that it is a legitimate condition due to these loss of neurons. And so what these neurons do is they project to the hypothalamus, right? And that projects to a bunch of the other sleep system centers. And so one of the specific projections is to the basal forebrain, which we've talked about earlier. And I've got a slide on the next one that kind of walks us through all the different systems. It also projects to the reticular formation, which is important for REM sleep, and the subcoryllis, which we've already talked about. Now, those axons from the subcoryllis also go to the tuberomammillary nucleus, which does have histamine projections. And so if you guys remember, histamine is important for keeping us alert and awake. If you take an antihistamine, it usually makes people drowsy. So a histamine is really important to help us remain awake and alert. And so, being able to have projections to and from the awake centers allow us to transition back and forth between sleep and wakefulness. And then those hypothalamic hypocretin neurons, they're controlling the position between the transition between sleep and wake. So wakefulness, non-REM, and REM sleep. So if you are going to lose these neurons, then you are essentially losing the ability to control that transition from wake to sleep, and then immediately seeing that person go directly into REM. And so here are some of the major systems here. So, this right here, this system right here, this is the basal forebrain. It helps to promote that slow wave deep sleep. And it does that by releasing GABA into the tuberomammillary nucleus. Now, remember, that's important for histamine, and histamine keeps us awake. And so if we have GABA inhibiting histamine center, then it's going to make us feel sleepy. So when you stimulate the basal forebrain, it's going to make animals sleepy. And if you have a lesion here, it's going to induce insomnia, keeping the person awake, because it's supposed to inhibit this tuberomammillary area with GABA. And here we have the brainstem, and this contains the reticular formation, which I've said before is not really a structure, but just kind of a line of neurons that go along the length of the brainstem, the pons, more so here. And so that is going to project axons and is going to activate the brain. And so if you stimulate this area, you're going to see wakefulness and alertness, and then lesions are going to produce constant sleep states, which in some cases could mean coma. Here we have, let's go backwards. Here, one more time. we have the subcarylis in orange here, and that's ventral to the locus coeruleus, which is in blue here. And that's widespread projections to promote REM. And when we have, if we sever this particular area or have, some disconnection, then we're going to see that muscle paralysis not happening, and that person would then basically act their dreams out. Here, D, we have the region here, which is the hypothalamus, using hypocretin, sending all of that, sending those signals to the other sleep centers to coordinate. So loss of these hypocretin cells is going to give us this disorganized sleep that we see in narcolepsy, right? And that is, we have muscle paralysis while we're awake. We see these sleep attacks that go immediately into REM, and all of those things. So just keeping in mind that these particular sleep centers are really important to managing sleep, wake, REM, non-REM, all of this cycles and transitions on a particular schedule. And when you mess any of these systems up, you're going to have an issue with either transitioning or not being able to do that thing. Now, just looking at these different parasomnias, we're going to talk about parasomnias and dysomnias. I'm going to try to erase my markings here just because we're having an issue here. Okay, so when looking at the different kinds of sleep disorders, we categorize them based off of kind of like when they occur, where they occur, what the kind of criteria are. And so we have parasomnias and dysomnias. So parasomnias, if you think about like paranormal, weird stuff, physical events, weird stuff that happens that shouldn't happen. Dysomnias are issues with timing. So like not falling asleep at the right time, not staying asleep, things like that. So, typically most people associate the timing dysomnias with like insomnia, but we'll go into different ones. So when we talk about dreams, typically we, are in REM sleep, and we've talked about this, a lot before. REM sleep is those very vivid, movie-like dreams. You feel like you're there, you feel like in real time, you may either be yourself or see yourself, as a third person. These are particular things that we typically experience in REM. And even if you don't, if you say, I never dream, I never remember my dreams, if you were to be in lab hooked up to polysomnography and you go into a REM state and you were woken up and somebody said, what were you thinking about? Chances are you would say, oh my goodness, I do remember something, and you would be able to recall it. So a lot of times people who don't remember their dreams are just not waking up at the prime time, or they forget them really quickly. There is a very small percentage of people that just don't seem to dream no matter how many times you wake them up during REM. Now there's a difference between a bad dream and a nightmare, and a lot of people don't realize that there is actually a distinction. A bad dream is one that's just a really anxiety, fear-provoking dream, but it's not something that's going to wake you up in the middle of the night. It's something that you wake up in the morning and you're like, ugh, I remember that dream, and it just really was not a good dream. So that's a bad dream. A nightmare is the same thing, except it's going to wake you up. So it's an anxiety, fear-provoking dream that wakes you up from REM sleep. And we see nightmares during REM because those tend to be very story-like, very vivid. Remember, we talked about there is some non-REM dreaming. We don't really call it dreaming. We call it mentation. And that's like not like a movie, but more of like pictures. It doesn't really have a story. It doesn't really have a lot of emotion tied to it. It's just kind of bland thinking. But the nightmares occur during REM. And we talked a little bit already about night terrors in class. Night terrors are those arousals that we get from non-REM sleep. Typically, the person who's experiencing the night terror does not remember whatever it was that like caused it. So sometimes you do have a person say they recall it like the next morning, and they say, oh, I remember having what felt like maybe a bad dream, or I felt scared, and I do recall something. But typically, the person will sort of wake. Not really wake, but look like they're awake. They're going to sit up in the bed. They are going to start screaming. They're going to flail their arms around. They might get up out of the bed. They're just acting like they're really, really terrified. And so this occurs during non-REM sleep because this is when you have some access to your motor centers, right? So if it was during REM, you would be completely paralyzed. So because you have access to your motor centers, you typically see a person sit up, waving their arms about, and they look really scared. Their eyes are sort of glassed over. So typically this is really scary for the person around them, and they might, be like, oh no, what's going on? So those people who are experiencing night terror will, after about 5 or so minutes, usually just lie back down and fall right back asleep. The person around them, though, might be kind of scared of like, oh my goodness, what just happened? Are they okay? And so the way that you handle a night terror is you let the person kind of safely just kind of flail it out. And then, if they get out of bed, kind of very gently lead them back to bed. Same thing with sleepwalking, which we typically see. It's going to be a non-REM too. You just, kind of be very, try not to wake them up. Just let them kind of guide them back to sleep. And the reason why we don't want to wake them up is because it is a deep sleep and you don't want to disorient them. They're going to be disoriented when they wake up, and then you don't want them to hit you or be, freaking out or anything. So, when the person, so what causes this, right? So typically one of the ideas is that during the night, especially in a child which has an immature brain, if the person is sleeping in a really uncomfortable position or sleeping with like their arms above their head and maybe their arms kind of lose the blood flow and they fall asleep and they get all tingly, this is a way for the brain to try to wake the body up to reposition. And so an immature brain may not be able to reposition on its own, whereas typically if you're in an uncomfortable position, you would just flip over to another position. And so likely what's happening is that the person is just really uncomfortable or in a painful position, and the body's just trying to do whatever it can to get them to reposition. That's one of the kind of ideas behind it. They're still trying to figure that out, but they've discovered that is a lot of times a trigger for that. What you can do is if a person, or especially a child, typically experience night terrors, you can wake them up within the first maybe 2 hours of sleep just to have them reposition. And a lot of times, because it happens earlier in the night, they actually won't experience a night terror. Some other conditions we talked about, narcolepsy, and so we see that the person is uncontrollably falling asleep at inappropriate times, and they typically will jump right into REM sleep. We know that this is caused by genetic mutation, basically that destroys these hypocretin orexin neuropeptides, these neurons that process this neuropeptide. Insomnia, we can see insomnia being a condition that there's multiple types of insomnia. So you can have issues falling asleep, you can have issues staying asleep, you can have issues with both. And so this is true inability to sleep. And there's not like, sometimes you talk to people and they say, oh, I'm an insomniac. I only get 3 hours of sleep per night. And you say, well, how much sleep do you try to get each night? And they say, oh no, I only lay down to get 3 hours. That's not insomnia. Insomnia is you give yourself 8 hours to sleep, you lie down, you simply cannot fall asleep. And typically we have a 20-minute rule. And that is, if you can't fall asleep in 20 minutes, get up, get out of your bed, move out of your room, don't turn on any electronics, maybe get a book, do something mundane. As you start to feel sleepy again, go back to your bed, give it another shot for 20 more minutes. And then if you're having trouble, get back up out of the bed and continue that cycle. So 20 minutes is kind of the rule of thumb there. It can be caused by a lot of things. It can be caused by hormones. It can be caused by drugs. It can be caused by stress. There's a really, really amazing treatment called CBTI, which is cognitive behavioral therapy for insomnia, that really helps to retrain the anxiety that's associated with insomnia to help people get better sleep. And of course, drug dependent insomnia. We see this sometimes when people get sort of they get used to taking hypnotics or sleep pills, and that is something that they start to kind of have a dependency on, and so that drug tolerance can result in deprivation of REM or non-REM sleep, and so the person's going to continuously try to increase the drug dose, and again, CBTI is one of the best treatments for insomnia and allows a person to try to treat their insomnia without the use of medication. And so, again, hypnotics should be something that you use when possible, that should be something that you use pretty much like as a temporary solution. Sleep apnea is a condition where the person either stops breathing throughout the night due to a full obstruction of their throat or their breathing airways, or a partial obstruction. It can be caused by things like obesity. It can be caused by medication. It can be caused by if you have a sinus infection, or it can be caused by anatomy. So you just have large tonsils, for example. And basically the person stops breathing. You can stop breathing hundreds of times throughout the night, and the person has to then wake up to breathe. So typically the person is feeling very tired in the morning, might have a headache due to increased pressure. And the treatment for that is called a CPAP, which is a continuous positive airway pressure, which basically forces the airways open and allows the person to continue to breathe throughout the night without stopping. And it's not oxygen, it just forces the airways through positive pressure, and allows the person, sometimes they call them like the Darth Vader masks, but they really do help people to be able to help, have a better night experience. So we've talked about this kind of sleep onset insomnia. Basically, a person has issues with falling asleep. And sometimes we see this caused by situational factors like shift work. If a person is trying to sleep during the day, they may have a really hard time falling asleep just because it is something that is not typical of how they sleep. Jet lag can also cause it. So if you are going in a different time zone and your body is on a different circadian rhythm, you can basically fighting against your body, and that can be difficult. Sleep maintenance insomnia is also an issue where you might have issues staying asleep. You also can see it caused by drugs or neurological factors. Alcohol can cause this too, because we actually metabolize alcohol really quickly. And so some people use alcohol as a nightcap, and it helps them fall asleep, but then it wakes them up because they've only been asleep for 2 or 3 hours and the body's already processed that. And now you're, alert again. So, just being mindful. But again, CBTI is a really, really fantastic treatment, and it's been shown to be even better than sleeping pills. And how do sleeping pills work? Well, they typically bind to those GABA receptors throughout the brain. But if you continue to use them, you can, of course, they eventually do become ineffective, and you do increase your tolerance for them. We do see that it does produce some changes in your sleep patterns, and if you stop using them, can sometimes continue. So just, being careful of that. And certain sleeping pills, if you use them for long term, can cause some drowsiness and memory gaps. There's been some indication that some sleeping pills are also potentially related to certain cancers, and so there's still a lot of more work being done on that. But again, sleeping pills really should be a temporary solution, along with something like CBTI to help maintain that insomnia. We've talked about sleep apnea just really briefly, but when the person stops breathing throughout their sleep, your blood oxygen level is going to drop, and that can essentially that can harm the brain, right? So anytime the brain is without oxygen, that can have the potential to damage the brain. So sometimes we see this because there's the relaxation in the muscles of the chest. They're too relaxed due to a medication, for example, throat cavity. So obstructive apnea may be from for example, if you have a really bad infection and all of your areas are inflamed, or you're taking medication that causes inflammation or whatever, or have something related to that, can lead to obstructive or partial obstructive apnea. You can also see that there may be some changes in the respiratory neurons, which would be central apnea. There's some really interesting conditions, especially in children, that you see that are genetic. And then you might see snoring, and we call this sort of heroic snoring, where a person is snoring so loud you can hear them several rooms over, or even outside. Now, not everybody who snores has apnea, and not everybody who has apnea snores. Not everybody who snores has apnea, not everybody who's apnea snores. So you don't have to have both together, but it usually is indicative, if you're snoring, that's an issue. Now, every time the person falls asleep, they have to basically wake back up to breathe, and that can cause basically fragmented sleep throughout the night. So there is a particular treatment. There's some that are more invasive than others. some with that have, for example, a removable tube, some with CPAP, which I've described before, basically to prevent the collapse of airways. You can also have surgeries that can help with that as well, especially if it's an anatomical issue. Now, if you do not treat your sleep apnea, if you do not use CPAP, for example, we have seen a lot of evidence that it relates to cardiovascular disorders, have a higher rate of stroke, heart attack, all those things and even later on, we're talking about people who are looking a lot like the short sleepers that might even be related to things like dementia and Alzheimer's from not letting the brain kind of do its thing during the night on a continuous basis. So, just making sure that if you are diagnosed with sleep apnea, that you do use a treatment, because it can be, and it's definitely been linked to cardiovascular disorders like stroke, heart attacks, things like that. So looking at the issues with REM sleep. So we haven't talked not a lot about the sleep paralysis, but this is something that's really important because a lot of people experience sleep paralysis and they feel like they're going crazy. So there was a relatively recent study done that examined how many students reported experiencing sleep paralysis, and about 30% of college students reported that they experienced sleep paralysis. What is this? Well, it's when you're asleep and you're basically sort of, as you're waking up, you feel like you can't move your body. You feel completely paralyzed. You're not able to move, but you are aware of your surroundings. And sometimes people experience hallucinations. And if you're doing this as you're waking up, you might experience a hypnopompic hallucination, and it feels like a dream, but feels very real. And you might experience like a demon on your chest, like this example, or a dark shadow in the room. Maybe somebody's going to try to hurt you. And it's very scary. It's very fear-provoking. And it feels like forever. It feels like it might have been a half an hour, but it's really only just a few seconds to a minute. And then your body and your brain kind of go on the same wavelength, and then you are able to move. But really what this is that the brain is inhibiting these motor neurons, but you're in a more conscious state. So it's kind of like a mismatch between sleep and wake, where your brain and body are not communicating properly. And any of these conditions, especially with sleep paralysis, is exacerbated by three things. So if you experience sleep paralysis really regularly, you can reduce the frequency of that happening by reducing your stress, because that's one of the number one things that can exacerbate these kinds of conditions. Caffeine, so reduce your amount of caffeine, and sleep deprivation. So if you are depriving yourself of sleep, then that is going to exacerbate these conditions. So make sure you reduce stress, caffeine, and get enough sleep, and that should see a reduction in your sleep paralysis. We've already talked about cataplexy, sort of that, kind of paralysis that happens with strong emotional stimulation. And so that's that loss of muscle tone. The hypnagogic hallucinations, these are those same thing as hypnopompic hallucinations, except they occur as you fall asleep. Some people do report sleep paralysis as they fall asleep and they experience the hypnagogic hallucinations, but a lot more people, I think, tend to say that those hallucinations happen as you are waking up. But again, these are not necessarily indicative of a serious problem, but you do want to make sure that you're reducing some of these things to try to reduce the frequency. Now, in children, we typically see night terrors, and we see that children do tend to grow out of those. We also see sleep enuresis, or bedwetting. Those are associated with slow wave sleep, that really deep sleep. When it comes to bedwetting, if the child is experiencing bedwetting regularly, like they have always been a bedwetter, it's actually not that much of a concern, even into 8, 9, 10 years old, because there are some systems that aren't mature yet. Now, if a child has not been a typical bedwetter and then suddenly starts to wet the bed for no reason, that might be an issue, either a neurological issue or another physiological issue that you would need to get checked out. So if it's something that's just kind of started out of the blue, then that's definitely something to get checked out. But if it's something that's always been there, it might just be that their system isn't mature yet, and we typically see them sort of grow out of that. It can be really embarrassing if you're going to, a sleepover and you, are worried about bedwetting. Sometimes, even older children might have to wear, disposable underwear. And then there's also some other ways, like you can wake children up earlier in the night to have them go to the bathroom again. There are some sensors, beds with sensors that basically the first kind of moisture, they'll actually alarm the child to wake up. So there's ways around this, but usually it's just an immaturity of the neurological system, and they'll grow out of that. Somnambulism is sleepwalking. Occurs during that deep, slow wave sleep, not during REM, because you're able to use your muscles. You're not acting out a dream. You usually are just doing kind of the normal thing that you do. So you might just kind of walk and look kind of like a zombie. You're a little glazed over. Your eyes are open. You're asleep, but you're not probably going to respond to anybody. A lot of people do things like they'll go and they'll eat something out of the refrigerator. They'll do something that they do every day. They might even walk outside. And if you wake somebody up, so it's you're not gonna like make their soul fall out of their body or anything like that. What it is that they don't really know what's going on. And so they don't have the ability to, they're super, super groggy. They're really disoriented. And while they're in this state, they really don't, really understand what's going on, and so they might bump into stuff, and they are just kind of doing things off of memory. Some people do have issues where they'll go in and they'll eat stuff out of the refrigerator. Sometimes people put locks in their refrigerator to try to avoid that, especially if children are doing it. But again, it's usually not indicative of any issue. A lot of times people will grow out of it, but it can persist in adulthood. Sometimes this is definitely exacerbated by stress. And so stress, caffeine, and sleep deprivation, same thing, also impacts these as well. Now, something that we typically see later on is things like REM behavior sleep disorder or REM behavior disorder, and we've talked a little bit about that before. This is where a person might have some kind of a brain damage or something to those areas of the brain that are supposed to inhibit the motor activation. Typically, we see this in older people, so really 50 and older, and we may see it as a result of Parkinson's, dementia, or Alzheimer's disease, and it's likely indicative of neurodegeneration because those areas, like subcrillus areas, might be damaged. And I've said before that can be a really dangerous condition because the person's acting out their dreams, and they might have a really scary dream where they are very violent, and they might fall out of the bed and hit their head. So you want to put them in a room that's really just a mattress, just for their safety. Another really interesting thing is that sudden infant death syndrome, or SIDS, this has been debated for quite a few years about the fact that SIDS is likely a sleep apnea condition. So SIDS is when an infant, really up until 1 year of age, just suddenly passes away in their sleep. And so for many years, we've tried to figure out what is causing this. It doesn't seem, there's no signs that there's anything wrong with the baby, and it just kind of just dies. And so what we really think is happening is that there are some infants just born and with a really immature respiratory pacemaker system or arousal mechanism, that they have this basically an apnea episode where they stop breathing, but their brain doesn't wake them up to start breathing again. And so one thing that has been that's been done to kind of alleviate this or help, I guess, prevent this rather, is putting babies on their back to sleep. And so this is to prevent that suffocation that we see due to basically an apnea episode. And so if you look at the trends, starting here where we can actually see when this trend was to start putting babies on their back to sleep, you can actually see a reduction in deaths from, you can see here from the 90s, which is where we would put babies on their stomachs, all the way to the early 2000s, where that trend of putting babies on their backs was much more common, and promoted in hospitals and things like that. So still trying to figure that out, but the evidence is really pointing to likely an apnea type disorder that's really difficult to predict in babies. So this is just a really nice, and if you want to kind of pause here and look at the different categories of disorders, we can categorize them in a lot of different ways by looking at parasomnia versus dysomnia. So parasomnia is things like weird things happening in your sleep, like the night terrors and things like that, and dysomnia is issues with timing, like insomnia. But really, this is a really good table to take a look at. So I highly encourage you to just take a minute to take a look. The last thing that I want to cover, and this is probably going to be the thing that's going to help you the most as just a sleeper, is just understanding proper sleep hygiene. So just like you have hygiene for your health, and making sure you take a shower and you wash your hands and you are clean. Sleep hygiene is a behavioral pattern set that and things that you can do, behaviors that you can do to promote healthy sleep. And this is preferable to any drug. So really, really good sleep hygiene, really understanding what kinds of actions you should do during the day and before bed to make your brain and body ready for bed. That is much better than any drug that you can take, because it will help you promote really, really good, healthy sleep. So first of all, melatonin has a weak hypnotic effect. Taking melatonin is something that your body already produces. We don't know what it does long-term. Supplements over the counter, there's really no way to know for sure exactly how much melatonin you're getting unless you're getting it prescribed by a doctor. Unless your doctor is prescribing it, really you don't have a good idea of how much you're getting. Also, melatonin release begins as the sun goes down, because naturally in your body, because it's inhibited by light. There are different kinds of melatonin that you can get. Some of them are slow release, some of them are fast release. If you take it at the wrong time of day, it can completely mess up your night and morning. You might fall asleep too early, or you might stay asleep too late, depending on what time you take it. So understanding how melatonin works and understanding what kind of supplement you have is very important. Giving it to children, we have no idea what long-term melatonin use starting in childhood does. We just haven't studied it in children that long. It could mean that they don't produce as much melatonin into adulthood as they're developing. This is a critical part of their development. So again, just knowing that just have to be careful with melatonin use, and it really shouldn't be a long-term solution for any reason, because you're naturally producing melatonin. You can instead impact your own release of melatonin by understanding how light works with your body, and that is reducing light exposure, especially blue light exposure at night. So doing things like you can wear blue blocking glasses at night, not during the day. You do not want to wear blue blockers during the day, because blue blockers during the day will make you feel sleepy all throughout the day. You want blue light exposure all throughout the day. That's really good. I know some companies market these blue blocking glasses to help reduce eye strain, but really you need that blue light exposure during the day, and you can reduce eye strain by simply taking small breaks throughout the day and resting your eyes. But you can use the blue light blockers at night, which are typically amber lenses, or using a screen on your computer or your device. I know that phones, for example, have a night mode. Using a night mode and having that kind of amber color will reduce your exposure. So reducing light exposure at night and making sure you have full sunlight exposure early in the morning, within 30 minutes of waking, for 30 minutes throughout the day, throughout the morning, really helpful to set your circadian rhythm. Caffeine, we know, is an antagonist to adenosine. Adenosine's job is to keep you, to start making you feel a little sleepy. And so when you consume caffeine, you're telling your brain that you're blocking these adenosine receptors. And so you're blocking adenosine from working, but adenosine will try to work. It's going to try to work. So what is it going to do? You're going to increase the number of adenosine receptors as you go, trying to make you feel sleepy. And so The more adenosine receptors you make, the less effective caffeine is. So then you consume more caffeine to counteract that. And it's just a continued cycle of developing an increased tolerance to caffeine. Caffeine exacerbates all sleep conditions and disorders. And so it makes everything worse, especially the closer that you take it to bedtime. So really sleep hygiene, reducing your caffeine or only reserving it for early in the morning, being really careful about melatonin use, keeping a routine that is the same, consistent go to bed at the same time during the evening, wake up in the same time, even on weekends, maintaining a really good, consistent schedule, have a dark room, but not too dark. You don't want, to block out all sunlight because you want the sun to come in the morning to set your circadian rhythm. Avoid that caffeine and avoid computer screens at night. This right here, a lot of really, really good tips. Okay. Consistency, sunlight in the mornings, avoid light at night. Make sure that your bedroom is a sleep inducing environment. This means anywhere between 65 to 67 degrees Fahrenheit. Making sure you have a really comfortable, cool room with lots of covers. Making sure you're dressed appropriately. Try to avoid caffeine, alcohol, nicotine, and large meals in the evening, right before bed. Having a pre-sleep routine. Maybe you have a bath. Go to bed when you're tired. And if you're not tired, get out of the bed. Give yourself 20 minutes to try to fall asleep. And if you're tossing and turning, get up. Go do something mundane and come back to bed when you're sleepy. If you're going to nap, do it earlier in the day. Do not do it close to bedtime. Do 20, 30, 60, or 90-minute nap. Don't go past 90 minutes because that's more than one cycle, but really 20 and 30-minute naps are really, really great little boosts throughout the day, but do it earlier in the day. The closer that you get to bedtime, the more you're going to start to infringe upon your sleep. Exercise. Now, exercise is a fun thing. This right here, this is only if, don't exercise late in the day, if it makes you alert. If exercise makes you tired, then go ahead and exercise later in the day. There's a lot of individual differences here, and you do it based off of what you know for your body, and listen to your body. Try to maintain these rhythms. And if you feel like something isn't working, then change it up. But try to give yourself at least 1 to 2 weeks of a really constant routine to see a change happen. So these hopefully will help you get a better night's sleep. And if you have any questions, you can ask, and have